good. Ashok, can you hear us?
Hi.
Yeah.
Yes, I can hear you very well. Can you hear me?
Very good. I think you all were eagerly waiting. You came from a
Good.
space. And so welcome to the Earth in the space. And then let me introduce here
Thank you.
Ravin
Thank you. And
Chakravarti.
it's a pleasure to be again. Sure.
Yeah. With me, I think Dr. Ravin Chakravarti on my right-hand side, T.S. Clare. The name is familiar too, I believe. Next to him is Vijay
Right.
Bang, and then Dr. Singh
Yes,
Velu,
of course,
Dr.
my
Rahman,
friends.
Dr. Ten, Dr.
Uh-huh.
Sharma. So we have people here eagerly waiting. Please tell us about your case.
Delta Azam. Okay. So what I have here is, and firstly, let me just introduce Dr. Vijay Kumar, my superb interventional cardiologist colleague. We have Dr. Babu and Dr. Gaurav, our very senior fellows, about to become consultants in interventional cardiology, both with us. So, Gaurav, why don't you present the case to them? Oh, you haven't got a mic? So Dr. Vijay will present the case.
Well, good morning, everybody. Today we have an interesting case where we would like to demonstrate multivessel PCI with the use of BVS scaffolds in a diabetic with triple vessel disease. So this is a 57 years gentleman who came to us with a recent worsening of angina from class 2 to class 3 in his past 5 to 6 months period. He had undergone a treadmill test also when he was class 2, having class 2 symptoms, and it was positive for reversible ischemia. His echo showed a normal LV systolic function, and the angiogram done electively revealed a triple vessel disease on the right and the left system, long diffuse lesions. Some of the vessels were small calibered, and the LAD was of a normal caliber. The Syntex score was 20, and the MACE at 4 years, calculated MACE, is almost the same for CABG and PCI, standing at 28% and 28%. So the option of CABG and PCI were both there, and obviously in this scenario, any patient would always prefer a non-surgical technique, and so he has been planned for an elective PCI. And we go ahead with the angio shots that we have
So
taken.
in the interest of time, and I know that you have 2 labs, let me just show you the angiogram. So can we switch to the angiogram, please? So we have here, you can see the left system, and it shows that it's got this OM, which is a long lesion in what looks like no more than a 2.5 millimeter vessel. There's an OM2, which is small, which is diffusely diseased. As you can see, we go to the next view. We have this multiple lesions in the LAD. As you can see, there's a distal lesion which seems to be high grade. One may argue that that distal lesion may require an FFR. Then there's a high grade lesion beyond the second diagonal. There is another high grade lesion in the proximal LAD. And you can see that the LAD disease spreads close to up to the ostium. As you can see, there's a mid segment looks like 3.5, but the proximal LAD looks like a 2.5. The mid LAD looks like a 3. So there is disease process there. So there's bifurcations there. Next. You can see that again, multiple lesions in the LAD. Next. You can see the circumflex disease clearly out here at the bifurcation. Next. More views of what you can see, and I said describe that proximal LAD is diseased, and you can see the ostium is large, but the proximal LAD is diseased, and then there's a high-grade stenosis. Next. And then you have this RCA, which in its body looks fine, but then there's a high-grade stenosis in what is a very large PDA, which goes up to the apex of the heart. Next. Okay, so here's multivessel disease, mildly calcified lesions. No, can we get this off? I don't know what's coming here. Can we get this off, and can we just get on to our angiogram, please? Okay, so now, again, in the interest of time, because you got to shift between two labs, I just want to say that we didn't want to demonstrate a very complex case. We just wanted to demonstrate, I mean, you've seen enough complex cases, both from me and other great operators. But the real issue was that could we demonstrate how safely and effectively to use BVS in multivessel disease? And I think that is very important to understand. The technique is what dictates the success of the BVSs. And any concerns about BVS can be overcome by good technique. So really what we wanted to do was demonstrate to you its use in multivessels, small and big vessels, overlaps, high pressure dills and everything. So in the meantime, do you want to discuss anything or should I go on, Ashwin?
Right, I think this is Robin. Ashok, what I was wondering that what is your strategy, and may I have some comments from the
Yes, Robin.
panelists? Dr. Tan, you can start.
Dr. Sengotiela here. Just have one question. It's a very nice case with triple vessel disease. I could see that the PDA looks like less than 2.5, 2.25, and the OM is also a little smaller. So with the Absorb 3 data showing not very encouraging result with smaller vessels, particularly less than 2.5, so do you have any concerns, or do you think the vessel size is around 2.5 or more?
Dr. Tan, can you have some comments from you?
Hi, Ashok, this is Hui Chim here.
So Sengatuvelu, great question, and I think this is a great question, and I would want to address that. This is, if anybody doesn't have a comment, I think Sengatuvelu's remarks are the most valid for such a case. Sengatuvelu, firstly, anything which you look visually as a 2.25 will invariably be the 2.5, even a 2.6 on an OCT. In fact, if you did a QCA, this would look like a much smaller vessel. So
Right.
you know that as well as I do. So for me, if it's looking like a 2.25, it is actually a 2.5 millimeter vessel. Remember the second aspect of it. The Absorb 3 had no systematic high pressure dilatations. I've myself shown the relevance of high pressure dilatations at OCT images, and it becomes even more important in these smaller vessels. It becomes very important to actually make sure that you have adequately sized high pressure dilatations, and most of these will end up at a 2.5 up to 20, 22 atmospheres of inflation. So actually, my personal data does not reflect the Absorb 3 data, to tell you frankly. And I have loads of such patients. As you know, Indians have smaller vessels, diffuse disease, multi-vessel implants, and I've used it extensively in what visually may be a 2.25 to a 2.5 vessel. For the 2.5 visuals, I go up to 2.75. For the 2.25 visuals, I go up to a 2.5 full pressure dilatation. So just let me demonstrate to you what we do in these sort of situations.
Well,
So the crux is high pressure dill.
no, I think there is no question
Now-
that the
Yeah.
eyeball impression is
Go ahead.
always underestimating the size of the artery. That is everyday experience, that when you do eyeballing, I think you always underestimate. And
And in addition, Dr. Mehta, this is underfilled because proximal is such a very tight stenosis. The proper sort of sizing may not be appropriate. Can I have a comment from Dr. Tan?
no, but even
Hey,
proximal,
Ashok, this
proximal
is-
vessel also, yeah.
There's only, and all these assessments should be after nitroglycerine.
Yeah, correct.
All these assessments should be after
Nitroglycerin
NTG
imaging will
intracoronary.
obviously change the sizing. Dr. Tan, can I have some quick comments from you?
Hi, Ashok, this is Tan Hui Chim here.
Yeah.
So this patient obviously has triple vessel
Alex
coronary
Tan, how
artery
are you? Great to see you. Great to hear from you.
Great to see you in action again. This patient has got triple vessel coronary artery disease, and to me, this patient will only benefit most from this LAD's lesions that is fairly diffuse. And I think there's reasons to use BRS here because this is a young patient. This is a very diffuse disease. If anything, with regard to BRS, this will be the ideal lesions to treat. But I probably will leave the RPDA as well as the circumflex alone and just concentrate on the LAD, given that this is going to be at least a procedure with 3 scaffolds, perhaps. and the cost can be quite exorbitant here.
Dr. Rahman, Abdul Rahman?
Yes. Ashok, this is Abdul from Bangladesh.
Yeah, so-
Actually, this is a really difficult and tough case. I think so in surgery, regarding the RCA, surgery is not a good option for that. And I will not touch the RCA, but I will definitely touch to the LED by BBS and maybe the LCX also, because OM is very big size vessel, OM1 or OM2 is a big, so I also would like to touch
Minus.
that also.
Right.
Just go to the
Could you
minus.
show
here.
us whatever you have done so far, Ashok?
Minus. So here the OM is fairly large, as you can see. The OM2, I would argue that can be left alone. It's diffusely diseased, but OM1 is large. Okay, so let me just show you, for interest of time, what we've done. And let's show you, okay. So that you don't waste time on your PDAs and OMs, can we just go forwards? And so here we go, next. And no, I would do this PDA. I mean, I think a BVS is a great option for this PDA. Next. And next. So we can keep showing, and then this is, so 7F guide, an all-star wire to provide good support for a distal high-grade stenosis. Next. A 2.25 balloon, and I always say near optimal size balloon to high pressure dilatation. There's a 2.25 to 22 atmospheres. Okay, so dilated adequately. Next. Next. A 2.5 millimeter scaffold over an all-star wire, positioning it accurately. There's a distal landing zone which has to be respected very carefully. It is a small vessel. We have to respect that distal landing zone. You can see how I respect it. I'm absolutely accurate. Next. Next, next. So dilatation as usual, and then going back with a 2.5 balloon. Next. And positioning it accurately. Next. And going up to 22 to 24 atmospheres into this vessel. Next.
So,
Next.
are you using any imaging to guide you?
Next. And next. Yeah. No. And I again can actually say very, very clearly, next, that if you get results like this with a 24 atmosphere inflation, with a step in and step down, here it is, next. And this is the final result, minus. If you get a result like this, which is bigger than the rest of the vessel, I don't see any role of imaging, is going to tell you, it's not going to tell you to go up any higher on this vessel.
Ashok, in 4 minutes'
I'm
time, we are
pretty
going to switch over to the other
about
lab.
results like this. And next, yeah. So I'm going to go on to showing you that this is a 2.5 now of what was a 2.25 millimeter vessel.
Yeah, perfect.
I'm confident about no imaging in Satni. This is what I said. Let's. So
Can you go to the next?
just go minus. I'll just show you the final result, which is this. Next. Okay, let's go to the next. I said, because I wanted to show you the LAD, I said I'll do the OM in the meantime. And again, a 2.25. Next. Yeah.
Ashok,
Yep.
this is clear here.
Next.
Can I comment?
And here it is. Yeah, clear?
You know, if you see
Yes, go ahead, comment.
If you see the right
Next.
coronary artery, the PDA distal to the stent, it's hardly a vessel actually. I really don't think it was worthwhile to do the right coronary artery. I mean, that's my view at least. There's very small artery left
It
beyond
goes to the
stenosis.
apex, Claire. Yeah, it goes to the apex. It could be argued either way. I'm not a proponent who's going to fight the battle on this issue. It's a personal opinion on these issues. Yes, it could be left. I don't think the patient would suffer greatly. I just felt that it was going around the apex and therefore might as well do it and give him the BVS and have a complete revascularization. I mean, there was an argument by
Sure.
Hoi Chim that OM could be left alone as well. Again, I'm not arguing about it.
No, I think if the surgeon was to handle this case, he would have bypassed it, so you should have done it. And you did it. I agree with you.
Any disease in the left main, sir? Is there any-
So I have dilated this OM again with a 2.25 to extreme high pressures of 22 atmospheres. I positioned a 28 into minus, go minus, yeah, next, and this is again at high pressure dilated, next, and a 2.5 into 28 millimeter scaffold has been implanted into this OM, and I'm just going to now do a post-dilatation. So by the time you come back, I will start showing you the LAD also.
Right. So have you sort of done anything on LAD? Meanwhile, can we get connected with the other center?
Yeah, you get connected. I will cross into the LAD after the post-dilatation of this OM,
Just
which
before
I
we-
will do with a
before we switch to
2.5
Ashok, just
balloon
be-
at 22 to 24 atmospheres, and I will go into the LAD.
I think is an issue is of
PDA,
yes, Madikar.
Still here?
about the PDA, we are discussing BVS or not, but I think it's a reasonable size PDA, which you need to stent. Whether BVS is the right option or not, that could be
I think,
debated.
Madikar, we can take an attitude like this, that if you have a reasonably easy and straightforward opportunity to revascularize any ischemic area whatsoever, like how effectively you can do a total revascularization and can be comparable. Like I would have believed that if this case was to be handed over to surgeon, he would have definitely bypassed a PDA. And therefore, I think it may be a reasonable approach to do this. I would say so.
I think
OM.
love more to discuss about LAD strategy, Ashok.
OM.
Planning here, because that's the most important and a complex.
No, you need to see something about the OM.
We don't want
No,
to
no,
miss
no.
that.
Hang on. You need to see something more about the OM.
Sure, sure.
And I think I'm here. No, I'm here to tell you certain things which are important and not for you to see a show. So please understand why I'm showing you this.
Sure.
Okay, now the important thing to understand is the issue which was raised by Senga Tuvelu, by Cheam, are you going to image this? And I said I won't image it because I know that if I follow my dogma of larger size balloon and high pressure post-DIL, I get adequate results. But just to demonstrate that, and the same thing I wrote up in the Eurointervention journal, is the single imaging fact that this vessel, after implantation of a 2.5 scaffold, was dilated with a 2.5 to 24 atmospheres distally, and then a 2.75 to 20 atmospheres. Now, the reason I say 2.75 is that if this visually looks to you as 2.5, then I would invariably dilate it with a 2.75 to 20 atmospheres. And what do I get on my OCT, which I did? And I wasn't going to do an OCT because I know what it would show, but I did it for you all so that you can see what it shows. And look what a 2.75 at 22 atmospheres does in that vessel. It actually does that. It actually makes it a 2.5 millimeter internally. And look at the struts. So 3 things I wrote up in that editorial and gave the OCT images. It actually enlarges the lumen further. It does away with any undilatable areas, despite the fact that you think that this is a 2.5, and it embeds the struts into the vessel wall. And can you just run that OCT? Is OCT connected?
Yeah, we can see the OCT image.
Can you run the OCT? No, I want the proximal part of it. I want the proximal part from where it is. Okay, can we just move away? No, further go distally. And now run it backwards. And you will see that the embedding of the struts, look at the way the struts are embedded into the intima. They almost, at some stages, start looking almost endothelialized into the vessel wall. That was the branch which you saw there.
Sure, yeah.
So what we have at the moment is a 2.75 dilated vessel. And you can see that you'll start seeing the embedded here. Can you see that?
Yes,
That
sir.
is what, so I don't even need to do an OCT to do something like this. I know I've got to go up with a 2.75. So that is where I say post-dilate with a quarter size higher balloon. Even when you have a perfect result, if you saw the 2.5, it was a perfect result. Go back 1 image to this. No, not the OCT, angio. Angio, this is the 2.75 balloon. Go minus. This is 2.75. Okay, this is after a 2.5, and you would have said this was great.
Ashok,
Okay.
This
So now
excellent-
let's do
excellent
the LED now.
Ashok,
So
Ashok,
the
Vijay
lesson
here.
is-
Ashok, Vijay here. Vijay Bang.
Yeah, Vijay.
Yeah, Ashok, I think it's great
Yes,
result.
Vijay.
I could see the boxes on the OCT very well.
Give me a 2.5.
Appreciate this.
Yep.
Right, we could see the OEM, and
Okay,
after
so
that,
now
what did you
here
do?
is the LED all of you wanted to discuss.
Yeah. You just show us the LED
Okay, so
part.
LED, let's go to the LED now. So LED has been wired here with an all-star. I have an extensive job. No, I want a 2.5. So you can see that there are lesions. We can either do proximal and then do a FFR to the distal lesion, or pre-decide that everything needs to be treated anyway. And if everything needs to be treated as I decided, then I started looking at the distal lesion, and I said, is there a place that I can actually just do the distal lesion separately and then do the proximal all together? Is there a space for 3 different scaffolds for each of the 3 lesions? And finally, after post-dilatation, and I'd used angiosculpt, by the way, and it's a great balloon for smaller vessels, which should have been also used on the OM. Next is that I finally, when I dilated all the 3 lesions with an angiosculpt, 2.5 millimeter angiosculpt, I started realizing, next. Firstly, it was pre-dilatation, and then there was angiosculpt. Next. This is angiosculpt at 14 atmospheres. Next. So you can start seeing that there's no way that you can do a good job if you start putting 3 separate scaffolds. The mid lesion practically merges into the distal lesion now. And so it's better to make sure that you just scaffold the whole of the vessel from the proximal, maybe distal, maybe the proximal could be a separate one, but certainly all the distal and mid should become a part of a single coverage. Next. Okay, this is the angiosculpt. Next. Okay, so we can go away the angiosculpt, high pressures, 17 atmospheres with the angiosculpt. And so now this is the first scaffold gone in.
And what length is
You
it?
can see that that's not fully, that area of the lesion did not have a complete dilatation. This is 28 millimeters, 2.5 into 28.
Right.
And this is where we are. Now, you will see me actually going in, and certainly at this, let me see
so
how
we'll
it
be disconnected.
responds
We'll be
to a
disconnected
2.5
soon. We are
to
going to the
22
other lab now,
atmospheres,
and
I may
we've got
actually
final
subsequently-
minutes. Meanwhile, you continue the case.
Okay,
Can
you
switch
go
over to
ahead.
the other lab,
By the
please?
time you come back, you will see.
Sure.
You will see. Correct. You'll see my high pressure dilatations.
Will not come back.
Go up 2, 4, 6,
Ashok,
8, 10, 12, 14, 16, 18, 20,
Ashok,
21.
let me tell you that we are not going to come back.
Yeah.
Whatever you want to say,
He's not here.
Okay.
I think whatever you have done is a great
great thing.
elegant demonstration of the
Go-
usage of
okay.
DRS in a very complex
So I
coronary
will
artery disease.
actually completely cover this vessel. Yeah. And it'll be end to end, by the way. I won't overlap it in smaller vessels. I'll put it end to end. I'll do OCT at the end of the day for this vessel because it's going to be a complete stent scaffold coverage of this vessel. And I will definitely do an OCT on this vessel because I feel it's important in this vessel and not the other vessels as you were discussing.
Excellent. Can you have a big hand for Dr. Sheth?
yeah.
Thank you. Wonderful demonstration, and congratulations for showing a good case.